Hello, and welcome to the Healthcare Facilities Network. I am your host, Peter Martin of Gosselin Martin Associates, and as always, thank you for clicking on this video. Today's offering is episode 2 of a conversation I had with Dr. Stephen Call of Washington State University. It's a long episode title, but we covered a lot of ground in here in this particular two-part series. It's called On Salaries, Infrastructure, Deferred Maintenance, and ROI. These are all terms that most facilities people, I was going to say hold near and dear, but they may not hold them near and dear. But this is the second part of the conversation. Steve and I, we kick it right off with talking about ROI. I also asked Steve during this episode, based on his research, and he's researching hospitals all across the country, how many hospitals are actually in a state of deferred maintenance? Meaning, what percentage of hospitals do you think, Steve, have maintenance needs that they are deferring? His answer may surprise you. We also talk a little bit about the mental health component of deferred maintenance. As we know, there's a very, deferred maintenance is deferred maintenance. You have equipment, you're not keeping up to date with servicing it. But what's the mental health component of that? And again, there definitely is. I mean, we know many directors, we know many people who, they just say, I cannot keep this going anymore. So we talk a little bit about that. As I said, Steve's research, he's one of the few people, if not the only person who is doing research into healthcare facilities management. We know that your hospitals, your CFOs, we did an episode on this, they always want you to quantify the data that you use, and Steve, through his research, does that. So I hope you'll watch this episode 2. I'll link to episode 1 at the very end. And with that, we will start off with episode 2. We're going to pick it up midstream. Thanks for watching.
In today's world, whether you're a politician or, you're on social media, those short, pithy statements seem to move people. This message is really simple, right? I mean, everybody can understand that if we spend this money up here, it's going to save us down here. And why doesn't that translate more broadly? Does your research indicate why isn't that a saleable point for people?
One reason I decided to focus on healthcare facility management for my research is because there's so much low-hanging fruit like this, where we all kind of intuitively know it.
Yeah.
But nobody's ever validated it or verified it through rigorous research. And so this is fun for me because it's like, this is a pretty simple thing, but now we have data and research to verify it. And secondly, how do you articulate this in a way that's effective? And that's, I think, the next step is to say, well, we get it, right? If we have adequate operational budgets, it's actually of benefit financially to the institution. Well, how do I kind of show those numbers? And so that's something that takes some time, and I do a lot of consulting and training in this to kind of help hospitals provide this sort of information. But that's what I would say is it's nothing like, nobody's ever researched healthcare facility management like I have. So it's new information, even though we all kind of know it.
How far behind other industries is healthcare relative to what you've just described, researching, moving forward? Is there a gap? Like, is healthcare 10 years, 15 years behind? And I guess it would matter the industry you're measuring it to, but say manufacturing or academia, how far behind on the adoptive curve, or how far behind is healthcare facility management from these other industries?
Yeah, I don't know if I have an answer for that. What I will say is that healthcare is unique in that we are typically not just occupiers, but owners and occupiers. So, and we have very complex facilities. So I don't think we're behind. I think everybody struggles with these things, but it's easier. I think the other industries have done a better job of connecting their facilities to as a critical component to their financial business decisions. And so I don't know if it's being behind or just that we're not focused on that in healthcare as much, even though we're being forced to focus on it now, because our buildings are to the point of aging, our workforce is aging, and how do we address it? So I think we're being forced to start thinking about it.
Do you ever look at, or not, do you ever look, I mean, I know you do, but the competition for dollars, the bucket's not limitless. I mean, you're competing against these other areas. Do things such as decarbonization, sustain, I mean, are these demands impacting operational too? Salary is one of them. I was thinking as you were talking, people want more salary. I don't blame them. They should. So salaries are higher. The demands from compliance and regulatory are more. It's more, but the bucket of dollars doesn't increase. How does that all impact this?
This is a great question, and I'll maybe answer it in some of the new research I'm doing on this issue of deferred maintenance backlog, right? Because we're saying we don't have enough money to even address our ongoing maintenance needs and our capital replacement needs, and so we just keep growing our backlog of deferred maintenance because it seems like there's a limited amount of funds, and facilities just doesn't seem to be getting enough to maintain what they need to maintain. And so some new research I did was actually showing that there is an ROI to actually reducing our deferred maintenance backlog. So there's a linear relationship between every dollar. So that's the simple way to put it is, for every dollar I spend reducing my deferred maintenance backlog, I generate, I think, $2.20 on hospital profitability.
Wow.
So there's the ROI, right?
So every dollar for deferred, you're generating $2.20 ROI for the hospital.
Every dollar I spend reducing my deferred maintenance backlog, it's generating more than $2 in profitability. So you can say, look, there's an ROI, there's an ROI to reducing our deferred maintenance backlog. However, the catch to this is there's also an ROI to not spending on deferred maintenance. and it actually exceeds. So healthcare administration is savvy enough to say, okay, well, I could get a 250% return on reducing my deferred maintenance backlog, or I could get a 900% return on average by buying a new MRI or opening some new clinics. So that limited amount of capital funds, it's being funneled towards those higher return opportunities. Now, that's what the research is showing. But what I'm also trying to do in the next step is saying, well, time out. This 250% return is actually not the full picture, because there's a lot of risk that may not be captured in the short term, right? So now we're saying, well, there's a return, but what if the roof collapses? Yeah. What if the generator fails? There's a huge amount of risk involved with not spending on that opportunity that's a smaller ROI. So an example of this is I just finished a big benchmarking, healthcare facility benchmarking study for IFMA. One of the questions in there was, are you experiencing deferred maintenance issues related to equipment failure? If so, what is the cost been to remediate that failure versus the original price just to correct the issue, right? And so what's looking like is a 3 to 4 times the cost. Wow. So if I have a roof repair that I need to do for $1 million, and I say, I don't have the money, I'm going to defer that, it's actually costing $3 to $4 million to make that correction in the future, because then it's a non-planned type situation, and it's causing all kinds of havoc. And by the way, that's also not even including the fact that 50% of these failures actually impact revenue. So now you start saying, okay, well, there's 250% plus, right? And so that number I don't have yet. But again, this is helpful in developing a business case to say, right, I've got $50 million of deferred maintenance. If we spend $50 million, it's going to impact our profitability. It's going to reduce our risks. And so now we can start having well, instead of the hospital saying, well, I only have $1 million of capital this year, we can say, well, good, that's fine. Maybe we should go take a loan. Maybe we should start, borrowing money at a lower interest rate and generating a return on that, on that loan. So there's a few things that I'm hoping can start moving the needle a little bit towards improving this aging infrastructure challenge.
Going back to your point about, well, you threw a lot out there, Steve. That's a lot. I don't know how you keep track of that stuff, but anyway, going back to your point about accounting for the risk, like for that roof, is there a formula, or how do you account for risk in your research? Because you're right. I mean, every winter you push that off, or every season you push that off, your risk increases. Do you account for that in the formulas you create?
Yeah, that's a great question, because that's historically been the challenge. Is we all know that, right? We're like, deferring this is just creating a bigger risk.
Yeah. Yeah, it's not going to get better.
It's not going to get better. It's probably going to cost us more. It's going to come at a time that's really inconvenient. And it's going to cost us more money. It's going to cost us all a huge headache. And so historically, we've just said that, right? We've talked to our CFO and said, well, I know you deferred this, but this is going to be really, this is going to be a problem. This is going to be risky. And so we talk about in qualitative terms, but now we're finally able, because of this research, to say we can start putting this in, quantifying the risk. So this is just one step towards that opportunity to quantify the risk. Now, what I don't know is that 3 to 4 times, right, the cost. Is that in 12 months? Is that in 5 years? Is that in 6? I mean, that's sort of the thing that I can't really articulate right now. But at least it's a step forward to say, at least we can start putting some dollar amounts to this business case of why we should be spending money.
This is Peter Martin. If you or your organization is interested in advertising or partnering with the Healthcare Facilities Network, including sponsoring content, then please email me using the barcode in the lower right of your screen. From the trades level to the vice president level, from planning, design, construction, project management, compliance, safety, and security, the Healthcare Facilities Network reaches FM people where FM people are. Relative to the deferred maintenance and backlogs, from your research, it might not be a fair question, but like, what percentage of hospitals, of American hospitals, are, do most have a deferred maintenance backlog? What percentage of folks are kind of spot on and doing what they need to do, achieving that 220, that payback, and what percentage are playing catch up, and how far back is the catch up?
That's a good question. And this new benchmarking study I did actually quantifies that. And I don't have the numbers in front of me, but it's about 50%.
Wow.
So just over 50% of the medical centers across the United States are in a state of deferred maintenance. I mean, they have some level of deferred maintenance, and just under half don't. They're able to kind of keep up with their aging infrastructure. They're adequately funded. So just about half and half on average.
And it's interesting. I mean, there's a cost we were talking about really early on. We were talking about not only retaining people, but finding people. And on my end, it's all anecdotal. I'm not like you. I'm not out there doing studies, but I know that there are a portion of folks who they're kind of worn down by that constant struggle to get funds and defer, and they know I have a risk with that boiler or that generator. I just can't keep it going anymore. And so there's also, we talk about cost in dollars and cents, but there's also a cost to your staff and your leadership, who reach a point where, like, I don't want to be on the news. I know what I have back here in my infrastructure, and I don't want to be here when it fails. Do you run into any of that when you're out there, conducting your research? Do you hear any of that?
Well, that's really astute, because I think there's I'll just say it. I think there's a mental health component to this. With these healthcare facilities, because I'll say because I've been in that position before, where you feel the responsibility of what you do as a healthcare facility, right? This is life good. This is life or death. It makes them good. They're committed to the mission. but there's this immense amount of stress and worry about this very issue. Oh man, I know I need to replace that roof. I know I need to replace that air handler. But I don't have the money, and I'm begging for it. But I just, you know, we don't have capital. So what can you do? This is in some ways, I think, helpful for these type of leaders, because you can now say, and again, it may not be as easy as just kind of, letting go, but to say, look, here's the risk.
Yeah.
Here's the risk in dollars. And I'm kind of putting, obviously you do this in a tactful way, but you say, I'm putting the administration on notice that this is the cost to the organization to make this decision. And so then I can kind of step back a little bit and say, I've done my job. I've done everything I can do. I've articulated this as clearly as possible with some real numbers, and the administration is making a business decision. And I hopefully won't get, come back and the hospital say, hey, we didn't know this, we didn't know this was going to happen. And so in some ways, it's not just the business case development. It's the assistance of the mental health and the stress levels of these leaders. And I felt that myself, working for different medical centers that didn't even have enough money, honestly, to meet their basic fire code and compliance issues, let alone aging infrastructure. So it's a real thing, and it's a hard thing to deal with.
Yeah, it really is. I mean, and you're unfortunately seeing, more and more of that. Going back, Stephen, to the infrastructure study that you did for facility ops in Washington State hospitals, it was, when I read it, I was like, oh, you studied Washington State hospitals because you are at Washington State University in your backyard. But when I read the study, it was interesting why you focused on Washington hospitals. Can you talk to a little bit about that?
Yeah, you would kind of make that assumption, right? Oh,
yes.
He's at Washington State University studying Washington State hospitals. But what's interesting about the state of Washington is the Department of Health requires each licensed hospital to provide their financial statements every year. And many states do that. But what's unique about Washington is they actually provide very detailed level of information on their financial statements. So I can actually drill down into the income statements specific to plant, to EVS, to dietary, so I can look at staffing levels. I can look at how much utility costs. And so I can get really good information within the state of Washington. I think there's 150 licensed beds. So yes, the research is looking at Washington hospitals, but there's enough hospitals that you can really say, hey, we can really generalize this across the nation.
That was one of the things I was thinking as I was reading it, as I was getting ready for our call. I put on my my hat where, okay, here's an FM, here's a director of FM trying to go to their leadership and say, hey, here's a study, you can find it. And then on my leadership level saying, hey, this is only Washington State.
Yeah.
And that's where I felt what you just said. There's enough commonality. I mean, it's not like Washington exists in this little silo that's just Washington State. I mean,
and these types of things, you have to kind of triangulate the information. So you've got this study, you have national, benchmarks that have been published, healthcare benchmarks published by IFMA in 2020, and then one forthcoming here later this year, early next year. So then those are a lot of, so you can say, well, yeah, this is one data set specific, but there's a lot of information out there to make these business cases, which is helpful.
Quick question, when we talk about FTEs per square foot, when you mentioned IFMA, and then I was thinking back to the ASHE benchmark that they did way back in 2013.
Yeah.
And whenever you talk to people and you see it on the ASHE listserv, hey, what do you use for employee per square foot? Is it one employee for 28, one employee for 40? Is your hospital new? Is your hospital old? There's all these variances. What is your approach to employees per square feet? Is that even relevant anymore? Have any comment on that?
In a vacuum, I don't think it's a very useful metric.
Mm-hmm.
And I'll explain. Number one, the 2013 benchmark doesn't include compensation expense and doesn't show you contracted or outsourced costs. So if I'm looking at my staffing levels, and I'm really high compared, relative to the benchmark, but my compensation is at benchmark, and my outsourcing costs are low, and my total costs are at benchmark, then I can say, yeah, my staffing levels are high, but that's because I'm not outsourcing as much, and I'm actually at benchmark for total cost, right? So that's the important thing to be looking at, not just what's your FTE per square foot. That's okay. It's not, from my opinion, it's not a very helpful tool to look at. Now, secondly, you have to understand, I think it's also helpful to dive a little deeper to say, well, what percent is management? What percent is technical staff? How's that broken? So there's a lot of deeper level analytics that can happen within that. And then lastly, this issue of what's the best benchmark, because you could say, well, FTE per square foot. You could say FTE per adjusted patient day, which was the metric that was, selected for the 2013 report. And so that's a lot of research that I've done to say, well, what are the best metrics? Yeah. What metric actually has the strongest association to FTEs? I joke that in some ways, so for example, if you look at patient days, which is a metric that works just fine for most hospitals except small hospitals. So if you're a critical access hospital and you're looking at FTEs per adjusted patient day, or whatever it is per adjusted patient day, there is no correlation at all. So you might as well just say, well, what's the number of pine trees in my parking lot per FTE? I mean, right? It's just it's an arbitrary metric that has no statistical correlation to what you're looking at. And so I've done a lot of research trying to say, well, what are those key metrics? And if you're at a large hospital, those common utilization metrics, admissions, discharges, patient days, et cetera, those are all fine. But it's when you get to those smaller hospitals. And so the best metric is actually plant, property, and equipment value. So that's a number on your balance sheet. So if you're looking at what's my FTE in essence, per the value of my facility, that's the metric. That's a metric that holds its correlation regardless of size, regardless of age of facility. It's a really, really strong metric.
That's interesting. So that's your go-to.
That's my go-to, but I always look, but I like to look at multiple metrics when I'm benchmarking it and understand the ranges, because every hospital is a little different. For example, I had a client where they had a large medical center in square feet, but they were primarily outpatients. So their patient days at admissions were really low. So gross square footage in that situation is a better metric because it's painting the picture of what's really going on. So you really have to be savvy and kind of understand, what the nuances of your hospital and what are the right metrics to be looking at.
So as a researcher, do you get, my word, not yours, is it frustrating for you when you see people just trying to go per FTE per square footage? Or are you thinking in your mind, no, we gotta dive deeper than that?
Well, it's not frustrating. What I would say, it's just not comprehensive. And so, what's your goal, right? What's your goal in benchmarking? A lot of times it's, hey, my CFO just told me I need to cut staff because they benchmarked me, and so they're trying to find some, what's great, but if you're really trying to say, well, I think the real value in benchmarking is looking at things comprehensively, understanding how you can justify your position of why you might be low or high, and then identifying where the key, where can I improve? Why am I so much lower or higher than my peers? And so it's that continuous process improvement is really what the benefit that comes from benchmarking, not just, oh, I'm trying to react to some pressure I'm getting about FTE levels.
Do you find, and I'm, just as I was listening to you talk, I thought of this, and I'm not asking you to speak about any clients, and you wouldn't do that obviously, but like in general, have you noticed, Steve, that from a governance or from a corporate perspective, are corporations more reactive now than they used to be? And let's just use 2020 when COVID hit as an example. It's arbitrary, but like, do organizations, whether it be healthcare or manufacturing or anything else, maybe what you did with HfN&x, Have corporations changed from that measured, balanced approach that you just talked about? It's comprehensive, we have good data, we're moving forward. Do they just want, is it more instantaneous gratification these days? And is that mindset translated up to higher levels of governance?
I think the challenge when it comes to, if we're talking benchmarking, how do we improve? How do we kind of measure ourselves internally and externally? I think the biggest barrier to that is really the decentral. A lot of times, even though I might be part of a centralized health system, the decision making is very decentralized. And so, why would I'm playing devil's advocate here, but why would I spend the energy and the money and the effort to benchmark when it's not going to, there's a perception that it's not going to do anything, or there's not a clear path internally to how to make these decisions. And there's just, been beaten down so many times over the years that it doesn't matter what you tell me, there's no capital. And so there's just a reluctance, right? There's so much to do as a healthcare facilitator. There's just, I think, sometimes a reluctance to spend the time and effort and money to benchmark, because the question is it really going to be worth it? I would argue it is definitely worth it. But there's sometimes a reluctance to spend the time and effort on it.
Yeah. So in our final couple of minutes here, as you can tell, Steve's dressed up today. He's got meetings, he's got class. I don't. Maybe I've got class, but I don't have your formal class. I don't know if I even have. But relative to your IFMA, you mentioned the benchmarking work you did with IFMA. That's coming out. I guess first question, that's just not hospitals, correct? What industries did you look at with the IFMA benchmarking study?
No, that's completely dedicated to healthcare.
Nice.
So again, ASHI IFMA, partnered on that original 2013 report that you just showed. IFMA had a follow-up report to that in 2020, and now they're going to have another follow-up report in 2023, 2024. So it's completely dedicated to healthcare.
Oh, nice.
And I think it's a hundreds of medical centers across the U.S. and even a little bit globally. Just a kind of a new interesting point. And it'll focus on not only plant engineering, but it'll benchmark EBS and laundry and linen and clinical engineering and some of those areas that would be of interest to a lot of facility leaders.
I was going to say, it's hard to believe this was 10 years ago now, coming up on 11. I mean, it's a great resource. I'm glad that there's a new one coming out, and I know you can't disclose anything, but did anything stick out to you that you could put a tease out for 2023, 2024 when this comes out?
Yeah, I think this report, my goal in this is to provide a resource that is very reliable and easy to use. So, historically, like I said, the 2013 report, if you were a small hospital and you were benchmarking your FTEs against adjusted patient days and it was off by 500%, you're like, what's going on? Well, it's because now this new report will actually, there's been statistical analysis and validation of the metrics to make sure that they're valid. So it's reliable, the multiple metrics. So it's not just square footage, it's not just adjusted patient days. It's actually other metrics that you can look at and kind of gauge where you're at, in a predictive type approach. So you can say, well, hey, I know my square footage, and I multiply it by a predictor number, and poof, this is the number I should be in. So it's a really easy to use. I'm optimistic it's going to be really well received, and worked on this with a group of healthcare facility leaders as well, and so there was great feedback on this. So I'm really excited for the report, and excited how it can help the industry.
Yeah. So what are you digging into next from your research perspective?
The interesting part of this IFMA study was actually realizing, when I was doing the statistical analysis, that there wasn't really much of a difference. Historically, when we've benchmarked, we've always said, okay, well, we'll break it out by region. We've got the West and the East. We'll break it out by type of hospital, acute care, and then we've got pediatrics, right? But when you look at the facility data, there was no really statistical difference between different regions, even like utilities, right? What do you think? And so it was really fascinating. So that's kind of my next step. is saying, putting together a research paper to show that there's some rationale to not necessarily needing to break out all these different levels, and we can kind of simplify the process of benchmarking through statistical validation. So that's kind of my next step, is probably writing a paper on that issue.
Well, that's interesting. I would, well, we'll look forward to that. I'm sure we'll talk for that. Anything else, Steve, we didn't get to? I mean, we could talk for a long time, but you got to work. Well, I guess I do, but anything
no, it's always a pleasure. I eat and breathe, healthcare facility management topics. So it's always a pleasure to talk with you. I know we kind of are in the same world and dealing with the same challenges. So I appreciate the opportunity to talk about it.
Can I ask you one last thing?
Absolutely.
And you could be really brief. How does your, as I was listening to you talk, how does your mind work? You know what I mean? Like, I was trying to, like, I'm not mathematical. I'm very visual and it's funny. I read this a couple of times. I haven't taken a real class in years. So I read it. I felt like I was back in college, but how does your mind work?
Well, I thoroughly enjoy identifying real ongoing problems in the industry and then trying to develop an innovative tool to help the industry. So that's where my mind is always thinking about, man, I know this is a problem. How can I help? How can I develop? And so I love the ability to kind of understand the industry. I've worked in it. I've been in this industry for a long time, and then using kind of the academic side of what I do to do some data analysis and develop some tools, and then go out and present and speak about it and train and help the industry. So my mind, that's usually where it's going, is how can I be helpful? What's something new I can provide to the industry that can really make a difference? And I get a lot of enjoyment out of that. And then helping individual health systems across the US on putting this into practice. So that's usually where my thoughts are. I still don't know how my mind works, but that's maybe one short answer.
Hey, at least it's working. Dr. Stephen Call from Washington State University and a background in healthcare facilities management. Thank you for your time today.
Thanks, Pete. Appreciate it.
Awesome. Have a great day. As always, thank you for watching the Healthcare Facilities Network. I'm Peter Martin.